Good afternoon. Whoops, that was loud. Hi, I'm Sharon Koivu. I'm involved with CSAM, and it's my great pleasure to welcome everyone this today at noon to an excellent presentation recognizing roadblocks adapting approaches for opioid agonist therapy in Canada. And it is my first of all, I want to make sure that it's really clear. There's no recording and no taking of pictures. I know I sometimes, when there's an excellent slide up there, I want to keep it for my records and take a picture of it. Please refrain. And there will be an opportunity to get slides later from this presentation, but there's no recording and no slides today for this event. It's my great honor and privilege to welcome the guest speaker, Dr. Vincent Lam. I think of him as one of the voices that I really enjoy hearing throughout all of this, that I think he's been a really important voice and an important person to listen to. Dr. Lam is an emergency physician and addiction physician who lives in Toronto. My condolences. And I'm saying that near the GTA. I live in Port Stanley. It's like the best place on the planet for anybody who wants to go to the best place on the planet outside of BC or the Maritimes. He is the medical director of, I'm going to say it wrong, Codrix Medical Clinic. He served as executive editor and co-author of the CAMH textbook, Opioid Agonist Therapy, A Prescriber's Guide to Treatment, published in 2022. And he is an award-winning author, and he has published a number of nonfiction and fiction books. And this is where I'm going to digress and tell a personal story that might seem like a weird segue, but this summer, my 96-year-old mother had been living very independently, and she died in August. And it was a very tragic time. And as we were going through her belongings and packing away her many, many books, I found Dr. Lam's book on Tommy Douglas. And that was like a moment of joy for me. I wasn't sure which was cooler, that my mother had Dr. Lam's book or that Dr. Lam wrote a book on Tommy Douglas. But it was really this absolute cool event for me to be able to sit down and find joy in the midst of something that was otherwise a bit of a tragedy for me. So I actually have a personal thank you to Dr. Lam for bringing joy to my life at that moment. So this session will examine challenges patients may face when being treated with an opioid agonist therapy and describe emerging best practices for opioid agonist therapy initiation and dosing. Clinical applications will be demonstrated through a case example. So my pleasure to welcome Dr. Lam.
Thanks so much for that really kind and generous introduction. Thank you to all of you for being here. Because I'm from Toronto, I always check my Google Maps before leaving the house. And I was quite happy when I checked my Google Maps this morning, and it said it would take me 58 minutes to get from my home in downtown Toronto to the Hamilton Convention Center. And by the time I managed to make a coffee and get dressed and throw a few things in a bag and get in the car, the driving time was 1 hour and 36 minutes. But I'm here, so what that proves is that it's worth the trouble to come to Hamilton. It's a great place, and I'm glad to be here. So this is a very practical session, and you know, there's going to be lots of moments to get your thoughts in the form of a show of hands survey, and I'm also hoping to learn from people in the room. I'm sure lots of people have experience in the areas that we're going to talk about, but some of us might have different experiences. So hopefully it's educational for all of us. And so I'm going to talk about recognizing roadblocks, adapting approaches to opioid agonist therapy, and certainly those of us who have been working for a couple of years have seen the landscape change, and we've seen changes in the illicit drug supply that our patients access, going from predominantly a mix of prescribed diverted opioids and heroin to fentanyl, and now again in some instances to again prescribed diverted opioids. But the mix in terms of the truly illicit supply has shifted from heroin to fentanyl. That's changed some of the challenges that we have, and I think it's also changed some of our approaches. So I do have some disclosures. I am receiving an honorarium for this presentation provided by Indivior. And in the past couple of years, I've received speaking honoraria by Indivior, Queen's University. As has been mentioned, I also write and publish books. I'm paid for doing that. I haven't written any non-fiction about opioids that I've been paid for, so there's no conflict there. I have full editorial control over this presentation, and I am going to be sharing with you things that I do which are off-label, and I'll try to flag those, and also I will point out that Indivior does not support any off-label use of its products, so it doesn't support claims that are not consistent with the terms of market authorization. We're going to try to look at some of the current challenges that all of us face. We're going to try to describe some of the emerging best practices, and we're going to use a case to try to walk us through. And it's a case which is entirely fictional, so I suppose I'm leaning on my fiction writer's credentials in this instance, but I hope it will feel familiar to all of you. So, a bit of a case introduction. This is Lawrence. Lawrence is a 29-year-old father, 2 kids, age 3 and 7. He's not staying with his partner, the father, or his ex-partner, the father of the children, because she kind of kept nagging him, you got to quit the pills. This led to relationship conflict. But there's no CAS issues. They live with their mom. He is from a small town in northern Ontario, and he has a strong family history of depression, alcohol use disorder, opioid use disorder. Sadly, his older brother, Brian, passed away from a fentanyl overdose. Lawrence has worked as a carpenter in the past, but they couldn't count on him. As he says, he was a bit unreliable in terms of showing up on time, and so currently is not working. He moved to Toronto, and it's kind of for a change of scenery. He heard that there were lots of jobs in Toronto, but hasn't managed to connect with one of those jobs yet, currently couch surfing with friends. So at the age of 12, and the way I always approach a history, and many of you may use a similar approach, or a different approach, but I usually ask people, look, I'd love to know the first time in your life that you used some kind of substance that changed how you felt or changed how the world felt. And, all kinds of responses come out of that question. And then I usually follow that up by finding out what the change was and how people felt that it helped them. And that gives me some sense of why substances were a solution at one point and continue to offer the promise of a solution, although they've started to cause problems. And so in this case, Lawrence began using alcohol at the age of 12, cannabis at 14. At 18, he was an active guy, active in sports. He broke his leg playing hockey and was started on acetaminophen oxycodone. So that helped with the pain, and it really helped him to feel more confident. He was previously, and still is, in many ways, a very shy person, anxious around others. But, when he took some of these pills, he felt really able to talk to others. He wasn't afraid of talking to other people. He felt more confident. And he discovered that he needed a few extra, more than the doctor was prescribing, in order for that effect to really continue after some time. And after a few months, he felt, gosh, when I can't get those pills, when people don't have them at the gym, when I'm not able to get my hands on them, I just kind of feel a bit fluey. I feel a bit down. I feel like maybe I'm depressed or something, but they really help me when I take them. I feel better, okay, and if I take enough, I feel confident. So after about 6 months, his family doctor said, Lawrence, really your x-ray looks good, leg looks good, cast is off, and guess what? You don't need the pills. Stop them. See you later. Okay. So what happened next is where we're going to go. But first, before we get there, I just want to kind of take a step back because I think a lot of us are in primary care, and even in the addiction space, we're often having conversations about pain. And so just, show of hands. Besides increasing the dose of prescribing opioids, What therapies have been found to be effective for managing chronic pain? The options, you can read them, so you can, instead of going through them twice, just put up your hands with the ones that seem right to you. A, exercise and physical therapy. Yeah, absolutely. Psychotherapy. Again, yes. I think everyone's saving themselves. Physical therapy. Yeah, and it's very hard to access, and so that's a real challenge for lots of folks. And all of the above. Yeah. Yeah, very important to remember this as we're dealing with painful conditions. And I think we also see the applicability of this in our patients who are not immediately in the recovery period following an acute injury, but who have chronic pain, and certainly people who have pain in the context of an opioid use disorder. And we also know that the behavioral activation piece can potentially have tremendous benefits in terms of mood and overall function. So, again, before we dive straight into all the OUD stuff, we just want to remember what it is exactly that brings so many of our patients to opioids, and why it becomes such an ongoing problem. And for many, the start of the story really is chronic non-cancer pain. And that's defined as pain which is present for more than 3 months or past the time of normal tissue healing. And there really is this multidisciplinary approach, which I think we're all aware of. And it's important just to remind ourselves that this really is the approach we should be taking. And we all come up against challenges, whether it's patient engagement, whether it's the resources which are available to them in the setting in which we work. But it's so relevant, so valuable in terms of helping our patients live alongside their pain. And one of the things I've started to do in terms of my language with people is I never say, let's get rid of your pain. I never say, let's beat your pain. Let's put the pain behind us. I never use those sorts of terms because I think they set up really an unrealistic expectation. And the expectation in itself can become a barrier in terms of people actually engaging in these strategies. So I always say, alongside your pain, what sorts of activity can you engage in alongside your pain? What can we do to help you get by alongside your pain? Because we all know that some degree of pain, once there is chronic non-cancer pain, it's likely to be present for a long time. And so we want to prioritize function alongside that pain. So Lawrence is in Toronto now, and in Toronto, he found hydromorphone. Turns out that was easier to find than acetaminophen, oxycodone. And he went from swallowing the pills to using them intravenously. Turned out that the friendly guy who had some hydromorphone also had some fentanyl, which was, quote, more bang for the buck. He tried fentanyl. This became his drug of choice. As you asked Lawrence, okay, what happened, and you're going through your DSM criteria, trying to understand, first of all, does this guy have an opioid use disorder? Trying to find out what sort of responsibilities it's impaired. In his case, you also discover, oh wow, so he actually had 2 non-fatal overdoses. One was reversed in an ambulance, one in an ED, and in neither case was he offered OAT or any follow-up, which is remarkable, and not that rare, really. I think we all know that from anecdotal experience. And the most recent study that I've seen, which looks at data, I believe from 2013 to 2020, don't quote me on the years, found that of people who experienced an opioid overdose in an ED, only 4% were initiated on OAT following that episode, which is remarkable. If you sort of imagine what we would say if only 4% of people who had an MI were offered aspirin or a thrombolytic or primary PCI, I think we would be aghast, and we should be aghast at this, but it's alarmingly common. We all know this story. Someone went to the ED, they had an overdose, they left, no OAT initiated. So at the time that he sees us, he continues to use 5 points of fentanyl every day, but he is kind of scared by these overdoses, and rightly so. He's got 2 kids. He does want to be there for them, and he is sick and tired of being sick and tired. He says, Doc, I want to quit everything. I want to quit the fentanyl, no more pills. He also tells you, look, if you put me on some medication, I want to get off it as soon as possible, as soon as I'm better. You guys know that that's the next thing that someone says. And you've gone through the criteria. I won't sort of spell them all out for you here, but you have established a DSM-5 diagnosis of opioid use disorder. So you begin to talk about treatment options. And again, I'm speaking to a knowledgeable audience. I won't give you the play-by-play there, but you tell him about methadone, you tell him about bupe, and he says, look, doc, yeah, I tried that bupe. I got so sick, I felt like worse than ever. But another guy, he had some of this stuff in a bottle, the methadone. I took that. It didn't help me completely, but it helped a bit. I want methadone. That's what I want. You try to talk to him about, the ceiling effect in terms of respiratory depression. You try to talk about comparative safety profiles. That's what I want, doc. Has anyone had this conversation? Right. Okay. All right. Easy show of hands. Okay, so great point. Someone had, and I'll repeat some of these comments because I'm not sure everyone can hear, but the point being that someone might choose methadone because they already know they're going to use again, and they're concerned that the interaction with bupe will lead them to withdrawal. So there's a certain level of self-awareness which may not always be disclosed, right? And that's realistic, and we have to respect that. We can also educate, I think, because I think quite commonly I have people who have the belief that if down and bupe are in the same room, they will be very, very sick, right? And so I think what you said is absolutely correct. That's often the motivation, and I think it's also really worthwhile, even if we're not doing bupe that day, to say, the order really matters. I say, look, if you, and we're going to get a bit more into this, if you take fentanyl first, 10 minutes later you take some bupe, yes, you will be sick as a dog. If you're sick as a dog and you take bupe and then you take fentanyl, in that sequence, the bupe won't make you sicker. And I think that's an important educational piece that we can share with people, whether or not we're actually initiating bupe that day. Never discount the education that we give today and its value potentially for the future. So, what's your management plan? So, option A, insist, right? It's much safer. Lawrence, it's got to be the bupe. You've got to try this before I even try the methadone. Who would do that? No one. Good. We have a room of compassionate realists. Wonderful. Good. Methadone 20 milligrams. Yeah. Oh, he's currently, so the question is, will he see the physician in the next 24 to 48 hours? Lawrence is currently speaking to the physician. Yeah. Yeah, so the comment is, when will his reassessment take place? And highlighting the principle that, we're always titrating, right? And the reassessment interval is important. Certainly in my practice setting, one of the luxuries we have is that we're typically prescribing to pharmacies where we know that the pharmacists are quite skilled and experienced in terms of reassessing people and are quite good at notifying us if there's sedation. But I think that principle of thinking about your setting, thinking about who is going to lay eyes on the patient, that there's someone who has experience and knowledge in assessing sedation, assessing drowsiness. And I think in some cases, yep, that can be a physician. In some cases, it would be a nurse or a pharmacist. Let's kind of make sure to move through the options. Option C, methadone 30 milligrams plus Cadian 200. Who would do that? Yeah, bunch of hands in the room. Methadone 40 milligrams. Yeah, and then And then a bunch of hands and some waving. Fair that it's always dependent on clinical circumstances and ability to reassess. Absolutely. So, I feel like I'm missing a slide. Oh, no, just not the order that I expected. So I wanted to, and to let you know, I think the latter two choices were the most common and are both choices that I would offer as options to the patient, and certainly in the presence of risk factors that made me more concerned about toxicity, like active heavy alcohol use, active ongoing heavy benzodiazepine use, I might lean towards 20 milligrams. Otherwise, I would typically offer either 30 milligrams of methadone and 200 of Cadian, or I would offer 40 milligrams of methadone. I see a question. That's a great question. Yeah, and so here then the question is also, is he methadone naive? Because you're absolutely right. So per the guidelines, we're really looking at someone who has been exposed to fentanyl and is using fentanyl, and someone where there has been experience with methadone. Now, in his case, he's used street methadone. And so for me, I'm pretty comfortable if someone's used street methadone and tolerated that, initiating methadone plus Cadian. But I think it would also be absolutely reasonable for someone to say, you know what, without a formal trial of methadone, I would initiate methadone monotherapy only. And I think you're thinking about the Medify guidelines, which do sort of predicate the co-prescription of methadone and Cadian upon the use of fentanyl and previous experience with methadone, if memory serves. Okay, so I just wanted to, so this is a decision that we're often trying to make. We're trying to decide between, we're offering both of these options. We're offering bupe, we're offering methadone. We're trying to guide people through a decision. And, we're deciding how hard we're going to lean on one side or another. So I want to share with you a recent trial that was published in JAMA just last month, and this was looking at bupe naloxone versus methadone for the treatment of OUD, and they were looking at the risk of treatment discontinuation as well as mortality, comparing these two groups of people. This was a retrospective study looking at health administrative data in BC. And it's quite interesting. So what they found, and so what they did is they had assessment period of, I believe, sometime in the aughts until 2020. And so they looked at people who were taking either bupe, SL, or methadone. So bupe sub-Q XR was not included in this study, and looked at the risk of treatment discontinuation, where that was defined as 5 days without methadone, 5 or more days without methadone, 6 or more days without bupe. And so it's quite interesting. They found that in that group, over a 24-month observation period, roughly speaking, 9 out of 10 of people who had been initiated on bupe at some point, 88.8%, and 8 out of 10 people who had been initiated on methadone, so let's say 8 out of 10, discontinued their treatment at some point in that period, right? So that's pretty interesting. And the risk of mortality was similar overall, except in the subgroup of people who were receiving a high dose of bupe. So in the subgroup of people who were receiving 24 milligrams or more of bupe, there was a mortality advantage in the bupe group. And overall, it should be noted that while the mortality, the incidence of mortality was similar, there was quite a wide hazard ratio. So on the mortality front, it was actually quite hard to know what was going on, taking the entire group. But this subgroup of high dose bupe had a mortality advantage. So, how to apply this information? And I thought what was actually most interesting for me was, and this I think lines up with clinical experience, was that whatever we start, most people are going to stop. And so I think the trial, certainly the way they've sort of framed their results is that, well, methadone has less discontinuation, true and fair, and I think that's important. But what it really sort of brought home to me was, wow, so whatever I start, either 8 or 9, or either 8 out of 10 or 9 out of 10 of these people will stop their treatment at some point in the next 2 years. And so the most interesting question for me is then, oh, okay, well, what next? Right? And the question for me is really, am I going to be able to start treatment again? And so for me, the answer is, I'm going to have a much better chance if my relationship with the patient is collaborative, cooperative, therapeutic. So whether it's 9 out of 10, whether it's 8 out of 10, my instinct is that if I force them to take something they really didn't want, and I said, no, you have to do this, right? Because I said so, and I read some papers, and it's much better, and that wasn't what they wanted, then my chance of being able to successfully reinitiate treatment after they've discontinued, because what this tells us is that most people will discontinue, is much lower than if we had a discussion, we collaborated on a decision, and they made that, and we made that decision together. Oh, right, there's the bup high dose subgroup. Okay, so just a review of some of the guidelines, and I realized that there's a guideline update at this conference, and these slides and this presentation was completed before that very recent guideline update. So take note of that. But those of us who have been practicing for a while remember there was a time when 30 milligrams was the absolute ceiling in terms of starting methadone. And now the BCCSU would give us some reassurance that if there's known risk or if there's known high tolerance, which is typically viewed as the use of fentanyl, then we're probably in a reasonable place to be starting up to 40 milligrams per day. Also, some of the changes from the guidelines that some of us remember. We probably remember some of the CPSO guidelines, which stipulated that above 80 milligrams, we could only titrate methadone every 5 days. And new guidelines would reassure us that even above doses of 85 milligrams, we can titrate every 3 days, although they would still recommend this smaller dose in titration. They would still recommend a 10 milligram titration dose versus the 15 milligram titration dose, which we would use at lower doses of methadone. And as always, physiology of human beings and pharmacology hasn't changed. The toxicity of the drug supply has changed, but we are still humans with the same bodies that we had 20 years ago. So we still have to think about the same concepts in terms of the way in which methadone takes a few days to reach a steady state serum level and the potential for a delayed emergence of respiratory depression. So to your point, we need to be reassessing patients frequently and carefully for these complications. A few cautions that you're all familiar with on the right-hand side. Okay, so in terms of the relatively new practice of supplementing Cadian with methadone, this comes from the BCCSU guidelines, where they would talk about, and some helpful commentary came out of us mentioning that already, but they would talk about starting at 200 milligrams. Or at up to 200 milligrams. I often start at, say, 100 milligrams of Cadian with 30 milligrams of methadone, and I titrate from there. They talk about, often up to 300 milligrams is sufficient, but based on individual clinical circumstances, one might need to titrate the Cadian above 300 milligrams. Okay, so Lawrence goes down this pathway of methadone and Cadian, and so over several visits, his dose is increased to 55 and 70 milligrams. Now, Lawrence still is in touch with his kids, cares about them, and he gets offered a job. And he says, Dr. Lamb, look, this is up in a camp. I have to be there 2 weeks at a time, but it'll mean I can send some money to my ex-partner and my kids, and I really like to do that. So we talk about the option of buprenorphine again, and he says, look, I've tried it a couple of times, but like I told you, doc, some guy gave it to me, I got really sick. He describes precipitated withdrawal. So I find that this is often a challenge to explain to people some of the physiology around precipitated withdrawal, and to try to help them appreciate that if bup is initiated in an appropriate clinical context with appropriate doses, that the chances of experiencing precipitated withdrawal are much lower. You start talking about partial agonists and receptor affinities and displacement from the mu-opioid receptor, and like people look as glazed as this room will by the end of Saturday, right? Just like, stop talking, give me a prescription. So here's a metaphor that I often use to explain the concept to people. And this works really well for people who are from Canada. I don't know if it works in any other country, right? I say, okay, so let's talk about this thing, right? This precipitated withdrawal. And I say, okay, so have you ever been outside in August and it was super hot and you came inside and you ran your hands under some water, just, room temperature water under the tap? And they say, yes. I say, okay, well, what was that like? They said, oh, well, it's water, it's cool, I guess, it's hot outside, so it's refreshing. And I say, yes. Have you ever been outside when it's minus 30 and you forgot your gloves and your hands are red and they're stinging, and you come in and you run them under the tap in the same tap, the same room temperature water? That's right. I heard someone say it. It hurts. It burns. It stings. It feels burning hot. Right? And people say, oh, yeah, right, I've done that. That's how it feels. And then I say, that's what we're talking about with the different kinds of opioids. It depends on what temperature you're coming from. So if you're already really, really hot, right, and we're adding something which is a middle temperature, well, you're going to feel like it's cold. If you're coming from, frostbitten, frozen hands, and we bring you to a middle temperature, it's going to feel really hot. And this is the same thing that can happen with buprenorphine, and probably did happen. If people have had this experience, you absolutely don't want to deny the experience. We absolutely want to say, yes, it sounds like you had precipitated withdrawal. And that was, you coming in from a super, super cold day. I mean, choose the temperature, the metaphor works either way. And suddenly this room temperature water was burning you. And often when I explain it in terms of water, people say, I get it. But not always. Sometimes people say, what the hell are you talking about? Okay. Another great metaphor about thawing meat. And the thing with metaphors is we can all choose our own, so absolutely we should. But there's another great one. This is a concept which is really, really important for us to keep in mind. And I think some patients are really interested in knowing about this as well. So this has to do with the ceiling with buprenorphine for respiratory depression. And so this is a trial from a number of years ago in an anesthesia journal where they actually took opioid naive people, so people who had no opioid tolerance, and gave them either 0.2 milligrams per kilo or 0.4 milligrams per kilo of buprenorphine, so fairly significant doses, and found they didn't stop breathing. So, that should be very reassuring to us. So Lawrence says, yeah, you know what? Fine. I'll try this bup stuff, right? And you explained to him a microdosing protocol. So I'm going to try it. I want to be able to get up and work at this camp. You managed to get him up to 16 milligrams, give him take-home doses for 2 weeks in the camp because you feel much more comfortable with take-home doses because of the lower risk for toxicity if diverted. Although I think, we should still be concerned about diversion, but we're less concerned about catastrophic consequences. And you say, okay, job well done, right? I fixed Lawrence. Yeehaw. He's on his way to camp. All is well. Not so soon, doctor. Lawrence comes back in a month and he says, yeah, you know what? I just needed more. So I took more, right? And I used it up in about 10 days. And yeah, I couldn't get any more of those pill things up there in the camp. So there was some guy with fentanyl. That's what I did. And Lawrence is really kind of feeling disheartened. He spent his time at the camp. He got that chunk of pay, but they told him, Lawrence, we'll call you. We'll just see whether we need you for the next rotation at camp. Don't call us, we'll call you. Right? So Lawrence is feeling, he's not really sure how this is going to work out. And he feels badly having gone back to fentanyl. He says, doctor, I effed up. Forget it. Just give me the methadone. So another poll. What would people say to Lawrence? Lawrence is like, I failed. Forget this boop. I want the methadone. Option A. Failure is if you are using any illicit substances, you are now a failure in this treatment program. No hands. Wise crowd. Failure is if you are not taking the treatment exactly as prescribed. Sure, it hasn't happened for anyone here or any of your patients. No, again, not too many hands. Failure is if you are taking the treatment, but it doesn't do what is expected. Silence. Failure is the end of the therapeutic relationship, meaning, patient says, screw you, you're not helping me. I have felt that way. I have felt like, gosh, like if you're firing me, I can't help you. And that's a hard one. I think if we, and there are various reasons why patients, either formally fire a care provider or just don't return when we hope they will. I think if we've provided compassionate, good care, then we hope there's more of a chance they'll come back. And there's also more of a chance if they've received some kind of benefit that they'll seek care from someone else who may be a better fit for whatever reasons, and that's fine. Or none of the above. Yeah, good. A lot of optimists. People like failure. What's failure? I'm in addiction medicine. I can't even think about that word. Otherwise, I wouldn't go to work. I have failure is death. And you know what? I struggle with that. I think overdose is absolutely an outcome that all of us seek passionately to avoid, right? And yet, no one says to an oncologist, if your patient dies, you've failed. Right? I think there has to be humility where we recognize we're treating a tough condition and it is tragic and unfortunate, but there will be deaths. And it doesn't mean that we haven't provided people with benefit. It doesn't mean that we haven't potentially provided people with more quality of life during the time that they have been in treatment. And that's a very accepted measure of care outcome in many fields of medicine. I see a hand over here.
I'd like to comment that failure as a clinician is when I give up, not when the patient gives up.
Okay.
Failure is when I stop trying.
To repeat, yeah, someone who says, failure is when the clinician gives up. All right. All right. I see the hands are down for the moment. The secret of life is to fall 7 times and to get up 8 times. So this is a great writer, Paulo Coelho, and I'm a writer, so I can tell you from experience. There's a lot of falling up and getting up if you're a writer, and it's probably the same if you're an addiction physician or a physician of any kind, or an addiction patient or a patient of any kind. You fall, but are you going to get up? Here's a few kind of like dialogues that I tend to use, right? And sometimes when I don't know what I'm going to say, I just think of some of these keywords. I use a lot of and. I use a lot of try. I use a lot of we, right? So, okay, yeah, I can understand. Yeah, like your mind is telling you that you're a failure, and so what can we do right now, right? Your mind is totally telling you that. I get it. And what can we do? What can you do that will move you in a direction that you want? I talk a lot about practice, right? And so sports are often a good metaphor. Have you ever tried a sport? Did you have to try a few times? Did you have to try again? Are you willing to try this, right? And with frustration, I think there can be, a more engaging way of bringing people on board than just saying like, I'm going to do this for you. It's going to be like this. We can just modify our language a bit and say, what can we do differently? Is there something we can do differently in the way this is prescribed? Is there something we can change in our approach? Now I see a hand, and what I'm going to do, because there's a few more slides, and I don't want to neglect the entirety of the presentation or the hands, so I'm going to kind of move through this, and then hopefully there will be some time for questions publicly, and then I'll be here for discussion afterwards. All right. So what's our goal? So our goal is really to try to figure out some kind of medications that make people more comfortable, that overcome cravings, that reduce, or if people wish to eliminate, eliminate the amount of unregulated drug use per their goals. Right? So we have to have realistic goals because, and those have to be nuanced because the world is not a black and white place. And often when I'm having difficult conversations with people about treatment options and what we could do differently and what we should do next, and, I'll often very, very explicitly use this metaphor, especially if people are kind of torn between, say, methadone and bupe or or whatever it is. I'll say, you know what? I just want you to know that this is like a restaurant. And I'm like the waiter in a restaurant. And for sure, if you went to any good restaurant, and I hope this is a pretty good restaurant, you know that you're going to choose what's on the menu, right? Because that's the way restaurants work. And that's the way it works here. Of the things we have on the menu, you will choose. At the end of this conversation, you will choose. But if I'm a good waiter in a good restaurant, I'm definitely going to tell you what I think is tasty, what the specials are today, what the chef is really good at, because otherwise I wouldn't be a good waiter. And after I tell you that, you can still choose whatever you want. I might tell you the pork chops are great, and you say, no, I want the tenderloin. Okay, right? This is a far more kind of dense slide than the other one. We all wish we were in a nice restaurant right now, and maybe we will be over the course of this weekend at some moment. But this is the menu that we're helping people to navigate in 2024 in terms of how to potentially initiate bupe. Right? It used to be when bupe first came onto the scene, there was one way, right? We started 4 milligrams, then gave 2, then 2. Come back the next day, we'll see what's going on, right? And now there's quite a few different ways of initiating bupe, and they range from the option which I just described, which is say second from the right, to a high dose approach, which is on the far left, what we call macrodosing, and a low gradual dosing approach called microdosing on the right-hand side. And so some of the patient factors to think about, to talk about, we can say, okay, yeah, like these are the reasons you might choose this from the menu. With the high-dose macro approach, that's really kind of fast. We can stabilize you quickly, right? It very quickly gives you access, and I should say that these are off-label, not approved by the manufacturer, in the cases of macro dosing and microdosing. And if you wish, it potentially brings us to a place where we can quite rapidly offer you buprenorphine subcutaneous XR. Again, this way of doing it, off-label, but this is what we talk about. And it might be a good choice for you if that's the endpoint that if one of those endpoints are what you want to get to quickly, either stabilization on a therapeutic dose of bup sublingual or access to bup sub-Q XR. If you want to kind of get there in a hurry, this might be a good option for you, and this is how we would do it. And in the case of microdosing, we might say, well, if you're in a situation where your opioid use is fairly stable, and maybe that's because you're being prescribed methadone, maybe it's because you're being prescribed something else, but you're trying to rotate away from that. Or maybe it's because you're using fentanyl, and realistically, you just don't really envision yourself stopping using fentanyl while you're in the midst of this stabilization process. But you don't mind it taking a week or two, depending on whether we're going to dose this twice a day or once a day. Then we can look at a low-dose microdosing approach, where we're going to gradually increase the dose of buprenorphine and hopefully significantly reduce the chances of you having withdrawal symptoms and avoiding precipitated withdrawal. So now a show of hands, all right? Some of the other slides were giveaways, right? There were either no right answers or it was just so obvious. But I'm curious what people would do in this situation. Would you restart bup through a microdose protocol and just send them off to camp with a microdosing regimen in a blister pack? Not too many. Oh, right. Sorry, I omitted part of the story. He wants to get back on because they did call him and said, this is the great thing about fiction writers, right? They're just like, oh yeah, just add it back into the plot, no problem. Or B, would you restart bup SL through a home induction protocol, more of a standard protocol? Yeah, some iffy. Okay. Would you restart through a macrodose protocol and hope to get him on a higher dose before he leaves for camp? Okay, a lot of fans there. Yeah. And would you restart bup through macrodose and give him sub-Q XR the next day? Yeah. Some fans there. Or would you even, engage him in, bup sub-Q XR just right away? Just like lie still, here you go. Right? So some people would embark in that approach. And there certainly are some places which are doing that. That's very much off-label. I've had experience with the first 4 options, and I'm probably most comfortable. I think these are all, perfectly valid menu items, and he can choose them based on his preference. Although, the first one I would hesitate, as I think many people did here, with the notion of sending someone away with a microdose blister pack. Not so much that in and of itself it would be dangerous, but just on their own at a remote camp, their chances of success might be reduced, right?
How quickly he needs to get on something, like what the time period is between now and when he goes to camp.
Yes. Yeah, excellent point, right? And I think that's exactly the kind of discussion. So just to repeat the question is, doesn't it matter how soon he needs to be in camp, basically? And I think you've absolutely identified one of the key things we need to talk about, right? How much time do you have? What's going on for you? All right, I'll take this one question, then I'll move straight along. Yeah. So that's a great question. What if he had fentanyl 30 hours ago, right? So in our setting, right, and again, off-label, right? Take it for what you will. But we've become quite comfortable and have had really, really reassuring results with macrodosing people who have abstained for, I'll put it 2 ways. So we have the scenario where people state that they've abstained for 24 hours and as far as I can tell, have abstained from fentanyl for 24 hours. And that tends to go very smoothly, right? So I'm going to show you a slide with some macrodosing dosages, a bit of a protocol in a moment. Great question, but I'm going to finish answering that question first, and then briefly comment, and then go on with the presentation. So, 30 hours, we would be more than comfortable initiating a macrodose. 24 hours of abstinence, we're also extremely comfortable. We don't really see a lot of adverse events with doing that. A fairly common scenario, in fact, is we see people who have a stated abstinence from fentanyl for 24 hours. And then after the first dose of a macrodose induction, begin to have some symptoms, right? And they say, oh, you know what? Actually, it was more like 12 hours, right? Very common scenario. And we've become quite comfortable with that. There's two things to that. One is what you do after that happens, but the more important thing is what you do before. So the thing you do after is you say, okay, we need to give you more bupe. We really need to load the receptors and get you comfortable. That's the thing you do after. But as I said, the more important thing is what you do before, right? So no matter what history people give me, I never say you're not going to have precipitated withdrawal. What I say is, I hope you're not going to have precipitated withdrawal, and we're going to do everything possible if we're getting the right information to reduce that chance. But if you do, we will get you through. And I'm telling you this now before I give you any medication, we will get you through by giving you more of the medication. And I'm telling you now because if I tell you afterwards, you're going to say, why should I take more of what just gave me sick? What just made me sick? So that's why I'm telling you now before I give you anything. So every macrodose induction has that little speech in it. And I think the before part is actually more important than the after, because you can't really get the after if you don't tell people before what you're going to do. Question, why didn't you just start methadone? I'll just say very quickly, also a legitimate option, but he wouldn't be able to go to camp with the methadone necessarily. We wouldn't be able to titrate it. Yeah. Yeah. Yeah, so great question. Kind of what are the ways we could navigate if he potentially wants methadone? And I think there are ways that you might potentially navigate methadone if that's what he wants at this moment, because we're a restaurant, right? And if that's what he chose, that's what we would do. I'm going to hold that question and we'll come back to it. I just want to make sure to get through the whole presentation. Oh, E. All right, there you go. So we have a very experienced provider who would just say, lie down, we're just doing sublocade. So this is amazing because this is me learning. Yeah, this is me learning, and thank you for that. I think some people might know this is Dr. Louisa Marion Balmar, who's a great pioneer and in both the use of buprenorphine and the reform of healthcare systems. So, all right. So I think we've already kind of jumped ahead into some of this content through the questions, but even though we might have kind of addressed it in kind of a Q&A fashion, let me just kind of go through this while you can see it in an organized way. So this is off-label, right? But this is a fairly common approach to macrodosing, right? Where with all the caveats and real-world customizations we already talked about, we would think about macrodosing someone if there's been 12 hours since their last short-acting prescribed opioid, 24 hours since last smoking or injecting fentanyl. I think about those interchangeably. Or 48 hours since their last long-acting prescribed opioid, such as Cadian, and 72 hours since any methadone. And then very commonly, what we'll do, and when we started to do this, this has changed a great deal, and evolved rapidly, thanks in large part to some wonderful people in this room. But when we started doing this, we were often starting with doses of 8 milligrams and then proceeding as described. Now, quite routinely, we're starting with doses of 16 milligrams, and then every 30, I sometimes wait a little bit longer if someone isn't uncomfortable, 30 to 60 minutes, another 8 milligrams, but you can definitely move more quickly than slowly. Some little nuances. So Ken Lee, also a great pioneer in this field, likes to pre-treat with ondansetron, in case there is any nausea, and that's fine. I mean, I think you can definitely do that. We don't have ondansetron readily available in our setting, so I don't tend to do that, and I find that it works quite well without that. And Ken favors using bupe film. Again, something you can experiment with in your practice. We've had great results both with bupe film as well as the sublingual tablets. But Ken's perspective is that because there's more complete absorption, that part we know, there's less risk of kind of getting that intermediate dose where someone might have precipitated withdrawal. Okay, so someone was asking, when is Lawrence going to camp? He's going in 2 days. So he wants to switch to bupe sub-Q XR. He says, look, yeah, I got to get this done, right? And you give him bupe sublingual 8 milligrams, because you're not sure what's going on. You're not sure about the full 16. Within 30 minutes, he's sweating. He's restless. He's having withdrawal. He's having precipitated withdrawal. And this is the thing, which is actually incredibly common. He says, yeah, you know what? It was actually about 12 hours ago. It wasn't the timeline I previously described. Happens all the time, right? And so I'm kind of laying this scenario out for you, A, because it happens all the time, and B, because if you appropriately prepare for it, it's really not something to be apprehensive about. What would you say to Lawrence? This is all your fault. You didn't tell me the truth. That's why you're feeling so sick right now. No hands. I can't do anything. Let's call 911. No, that's not going to help. There's a guy in the waiting room. He's got some fentanyl. All right, fine. Or let's give you some more medication to get you comfortable. I feel like I've already kind of talked through this, so I'm going to, move on. But this is the thing you have to know. If you run into trouble with a macro dose, the first and likely the only thing you will need to do is give people more bupe, fill the receptors as quickly as possible to relieve people's withdrawal.
Just to kind of give them a bit more of that comfort while they're waiting for all of that comfort.
Yeah, question about setting, right? So we certainly have a room that we employ for this, right? And it's nothing fancy, right? It's a room which so where we have a massage table. We actually don't offer massages, but that was the table which was available to us. So it's a padded, comfortable table. It can be closed. It can be private. It's a good point. So I think it's very worthwhile to have a setting where people can be calm and on their own. I don't think it's 100% necessary that they be able to lie down. I think it's a nice thing, for sure. And when I initially thought about doing this, I thought, okay, well, do I need a nurse? Do I need, and I come from an emergency medicine background, right? So everything is, okay, what are my resources? What monitoring do I have? Do I have real-time telemetry? Do I have O2 sat monitoring? And I'll tell you, in the addiction medicine setting where I work, I have none of that, right? So it's solo coverage by a physician most of the time. Sometimes there's a fellow, but we certainly do this not supported by nursing, just in a room, just a quiet, clean, comfortable space. And it's got a massage table, so, that helps. But here are some other things that you can do. So if giving more bupe doesn't resolve the symptoms, in my experience, it always has, off-label. You can also try using some clonidine. I know some colleagues will use hydromorphone. I actually don't. Some colleagues have reported using things like metoclopramide, Haldol. I've actually never done that, full disclosure. But I'm including it here, and I've never needed to. But I'm including it here for completeness, as I know these are strategies that colleagues have employed to handle some of the symptoms of precipitated withdrawal. And so I'm curious to get a sense of where people are. So we're going to macrodose him, and his goal is he wants to get on the sub-Q XR. He wants to go to camp in 2 days. I'm curious where people are right now in terms of their practice with the bup sub-Q XR. So the monthly injectable formulation of buprenorphine. How many people are at A? They're kind of curious about how it might fit into their practice, not really using it yet. No? Okay. And how many people, use bup sub-Q XR, but always per monograph? So 1 week kind of, with the bup SL at least 8 milligrams. Okay. Also not too many people. How many people, usually use it in accordance with a monograph? So that 1 week kind of lead-in period with sublingual, but, occasionally we'll kind of modify and customize. Okay, so yeah, a lot of folks. Right, yeah. So commentary that, maybe I would modify it more, but sometimes the drug benefits issues are an impediment. And how many people are D? They just routinely use it, per clinical judgment off-label. Yeah, so that's where I'm at too. And there's no right place to be. There's no right or wrong place to be. And everyone is going to have to figure out what makes sense in their practice. But I'm just really curious about where people are at with that. So I will share with you one more trial. And so this is an interesting trial. This was published last December of 2023. And so this is looking at a comparison between bup sub-Q XR versus daily standard of care. So this was actually a randomized prospective trial, open label, although the statisticians were later blinded. And they basically took people in a clinic and randomized them. And if they randomized to the treatment arm, they received or could receive bup sub-Q XR, and otherwise they received either methadone or bup SL. So it was one of those two options within the standard of care arm. And their main outcomes were to look at the number of days that trial subjects / patients were abstinent of opioids, as well as a host of other secondary outcome measures. Here's the graphic. The graphic is really kind of the best way of representing their results. So what you're looking at here is 2 plots of standard of care and then bup sub-Q XR. There were 300 some people enrolled in the trial overall. And where you see that white triangle, that's where people were lost to follow-up or didn't continue in the trial. And then the little red points are where people used illicit opioids, and then the green is where people did not use illicit opioids. So there was a distinct advantage for bup sub-Q XR versus standard of care. So for the bup sub-Q XR, there was a mean of 104 days of abstinence from opioids, and in the standard of care group, there was a mean of 123 days of abstinence. So a significant difference, and also a difference in terms of the length of time, the mean length of time that people remained in treatment. So some of the precautions to think about with bup sub-Q XR. One of the important things that we need to think about whenever we're using opioids is there is always a potential for sedation, for respiratory depression. And I feel as if I'm sort of saying two things at the same time here, because I showed you that previous slide showing that anesthesia trial in which it looked like bupe was pretty safe. And I think that's true. And then I think at the same time, we also have to always recognize the theoretical risk whenever using an opioid of respiratory depression and a bad outcome. The way I think about this clinically is, for me clinically, I'm quite comfortable and really routinely will be using bupe SL and bupe sub-Q XR in an off-label manner for folks who have a history of using fentanyl. And there I feel quite confident that their tolerance is high. And I also feel that it's quite reasonable in terms of the risk-benefit equation, that I'm hopefully providing more benefit than risk. And of course, we are still seeing patients who have not had any exposure to fentanyl and who may have only had exposure to prescribed opioids. And so actually in that group, I'm still quite orthodox and I'm still quite adherent to, to product monograph and guideline standards, because I feel that that's a group where I'm not entirely sure that the risk-benefit equation falls on the side of me stepping into the off-label territory. So that's how I kind of navigate some of these issues, and of course you will decide how to navigate them in your own practice. So QT prolongation, it's noted in the product monograph. It hasn't really been seen in clinical studies. But if you have someone with a history of QT prolongation, maybe you want to check their ECG before using bupe sub-Q XR. There have been case reports of severe liver disease and death. So it's really unclear whether that's associated or whether that's causative. But I'll tell you, in my setting, practically speaking, I'm not routinely ordering LFTs before using bupe or bupe sub-Q XR unless there is a clear history of some sort of liver pathology, and that obviously would mean that someone should be worked up for that. Pregnancy, be very cautious. It's not indicated in pregnancy. There is some concern around the gel product, and the safety is unknown. And so bupe sub-Q XR is not intended for folks who are pregnant. Having said that, if you have someone who is receiving this product and who becomes pregnant, I don't think it's necessary to immediately panic and become very upset, but you would switch them to a different product that doesn't have the gel component which exists in the bupe sub-Q XR. All right, so these are some of the things from the monograph. So in that territory where we're using the monograph, and so this is me if I'm taking care of a patient who, say, has only used hydromorphone or oxycodone and presents to me for treatment of OUD and wants to choose the bupe sub-Q XR from the menu. So there we would be initiating them on bupe SL in the normal fashion, and then only think about the bupe sub-Q XR after 7 days on at least 8 milligrams. We would be administering the bupe sub-Q XR at a minimum of 26 days between doses, and then up to 2 weeks afterwards. So beyond the 26 days, we could continue without any interruption. We would administer 300 and 300 for one, the first injection, and then the second one with 100 to follow. And we would also keep in mind if they want to travel, we could give them, say, 300 milligrams for 2 months, for instance, to travel. So this is entirely, orthodox per the monograph, entirely sanctioned by the powers that be. Now, of course, in terms of my clinical practice, and I'm curious. I mean, this may reflect many of your clinical practices as well, or it may not. There's definitely a lot of common modifications which I employ and my colleagues employ in terms of how we use bup sub-Q XR. So quite common, to macrodose with bup SL and then follow on the same day. And the same day is actually really great because then you've really initiated someone on a stabilizing treatment. But the same day or the next day with bup sub-Q XR. If someone says, look, and here the scenario is often someone has received bup sub-Q XR in the past, has been off for a few months and says, look, I just want to get back on it. I want to get back on it. I know that some more experienced people in the room would just give it to them, away you go, right? I've been in the habit of giving them bup 8 milligrams SL, and maybe that's just for my own peace of mind. It's mostly so that, okay, if they're going to precipitate, I can then do something else and deal with their precipitated withdrawal, and then give them an injection of bup sub-Q XR. Very, very commonly, we do find that people might feel a bit uncomfortable, especially in the earlier injections, especially towards the end of the 4-week period. And then we very routinely supplement bup sub-Q XR with bup SL. Also very common, especially in the early injections, that at about the 3-week point, people say, look, I'm a bit uncomfortable, I'm getting some withdrawal, right? And so here there's a couple of options. We can supplement with bup SL, or we can give another injection. The issue of the ODB coverage has been raised, and it is an issue because I think formally speaking, ODB will only cover it at, I believe it's actually 28 days. So, it turns out, and this will depend on your setting, your comfort level, as well as the setting and comfort level of your pharmacists. In our setting, what we do is, and it turns out I learned the pharmacists can override that somehow. They can override it, right? Right. Somehow in the computer land of the pharmacists, they can override it earlier. The question is it 26 days that they can override it? I definitely know they can override it. They can put it through, right, and get paid for it in Ontario. And then their concern, which they've raised with me, is, well, I guess I'm taking the risk I won't get paid, right? And so the approach we take is, I write a very clear note in the prescription. I say, for essential life-saving reasons, I feel that this should be dispensed and covered prior to the 4-week period. I've never heard of any bad thing coming from that. That's not only, yeah.
The pharmacist will. So it's just a little trick. I know it works.
There you are.
We were in the same situation, but if you write for life-saving measures, it's overridden by the pharmacist. They have a code, and that code gets sent. Whatever that code is gets sent to ODB, and it's considered good. And it works for NIHB.
I don't think NIHB has a problem with it.
No, they did initially.
Corrections don't have a problem.
Sorry, initially NIHB, like this was all started.
Wants to stay as close to the monitor as possible.
Correction. Well, I work in corrections, but immediately. But yeah, just so you know, if you write for life-saving measures, the pharmacist has a code that matches that.
Okay, great. So don't take it from me. Take it from a wonderful person.
ODB told me right now, so I didn't write that.
Good. All right. For life-saving measures. Those are the keywords. Amazing. I'll write less because now I know that's all I have to write. Okay. And then quite commonly, we're often seeing that folks who either have used fentanyl or continue to use fentanyl, and also not rare, so don't feel like somehow, you have, quote, failed or the treatment has failed if there is some ongoing fentanyl use. And people often will tell me, I'm still using, but I'm using less often. I feel like I'm able to control when I'm able to use. I have money. I'm not doing things I don't want to do in order to obtain fentanyl. And by the way, it doesn't really get me as high as it used to. But often in settings where people are continuing to use some fentanyl, quite commonly we're continuing to maintain the bube sub-Q XR at 300 milligrams per month, and that seems to be necessary. All right, so I'm going to, I know we're coming up on the end of our time, and I know there's lots of vigorous discussion, which is amazing. So I'm just going to say there are other things that we need to be talking about with Lawrence, right? So there's the pharmacotherapy piece. We need to be talking with him about everything that can help to support his stability. So seeking safety, distress tolerance skills. We need to really emphasize when things are working. I think we're really great at asking people, okay, how did you slip? Why did you relapse? How did you get triggered? Blah, blah, blah. Okay, that's fine. That's legitimate conversation. I think it's even more important when people have a success. Whether it's that they used much less this month or they went a week without using, to ask, okay, so what worked, right? And if they say, oh, I just tried harder, my advice to you is don't stop the conversation, right? Don't just say, okay, great, you tried harder. All right, see you later, right? Say, oh, okay, you tried harder. What did that look like? What did you do, right? So get people to try to be explicit about what it meant for them to try harder. And sometimes they'll just say, oh, I just tried harder. That's it. And that's okay. I mean, you'll continue the conversation, but sometimes they'll tell you what it meant in terms of them speaking to a trusted person in their lives, in terms of them, giving someone else their money to hold on to, in terms of them engaging in other valued activities. So ask them, what worked and what did it look like? All right. So I'm going to close my remarks here. A few minutes for questions. I see lots of hands popping up, which is amazing. And if people have to go, I get it. But yes.
Using the sub-QXR as a mechanism of tapering him off the buprenorphine?
Yeah, great question. And I think I'm probably sitting right there with you, where I have a lot of curiosity about that. And I think there was some discussion early on, and there certainly is discussion now, about this potentially being a really useful tool in terms of tapering people because the serum concentrations would just gradually decrease. And it's not clear from a literature point of view what the best strategy is to do that. I have to say that in my practice, I can't say that I've seen it be immensely successful. And that may be because more knowledge is forthcoming, and in 4 or 5 years, or maybe 4 or 5 months, we will know how to do it well. But in my practice, what I've typically seen is that when people try to do that, they try it for a while, they return, they're uncomfortable, and we have to decide what to do. Whether to resume a course of bube sub-QXR or something else. Now, that's obviously biased by the possibility that there may be people who simply haven't come back because that strategy was successful. So I think that's a very long-winded way of saying I'm very hopeful, as some of our patients are, that this may play a role in an exit strategy, but I can't tell you that I know exactly how to do it. Okay, great. Okay, so for those who haven't heard, there's someone here who has had some success with that. Right. And just to repeat in case it didn't amplify back there, the strategy employed here, has been to go from 300 to 100, support, offer adjunctive medications in the form of clonidine, and make them aware that it'll remain in their system for a while. Now, before I forget, I've been reminded there is an evaluation survey. You can keep on asking questions, but if you wish, you can scan the QR code and evaluate moi. Yes.
The graph that you showed of respiratory depression to buprenorphine, I've looked at that for a number of years. What it shows is that the respiratory rate reduced from 25 to 12 to 15. Now, a respiratory rate of 25 is sick or anxious. To reduce the respiratory rate from 25 to 12 to 15 is to go from abnormal, that is the people studied were anxious, they took the buprenorphine, reduced to 12 to 15. Their respiratory rate halved from sick to normal. Now that graph has been shown as respiratory depression for all those years, but in fact it's respiratory normalization. And the next graph in that paper shows that the respiratory rate increased when naloxone was administered. And in fact, that is needle phobia. If you came and gave me a jab of naloxone, I bet you my respiratory rate would increase from normal 12 to 15 up to 18 or 20. Now, I think that's really important because for 20 years I've been looking for respiratory depression to buprenorphine. In my practice at home in Australia, I treat 500 people with 32 milligrams frequently. They all come from an opioid dependent, that is, adapted position. I haven't seen respiratory depression. The two cases in my general hospital that people have been treated for respiratory depression to buprenorphine have responded to a single dose of naloxone. Buprenorphine lasts for 20 hours, naloxone lasts for 20 minutes. So those two cases don't pass the test. The naloxone didn't wake them up. The activity woke the patient up. You come and huddle around me, give me a jab of naloxone, I'll say, what's going on? But the naloxone wears off in 20 minutes. If my respiratory rate was low because of buprenorphine, it will be low again in 20 minutes. So I haven't seen buprenorphine respiratory depression. I've been going to conferences here for the last 15 years. No one has answered that to me. And that study that you showed distinctly does not show respiratory depression, because if I'm breathing 25 per minute, I'm a sick man. And if you lower that to 12 to 15, you've actually made me better.
Thank you. Very interesting commentary. And I think from a reassurance point of view, it kind of bolsters the comfort that we should feel with buprenorphine. Excellent observation. Thank you.
And I've given doses of buprenorphine well over 100 milligrams within 1 to 2 hours, and I've never had respiratory depression. And that's typically in cases where I always say if you don't give enough buprenorphine, if you haven't seen precipitate withdrawal, you haven't given enough buprenorphine. And that's the truth, is you are going to put people in precipitate withdrawal. But most of these have been in a controlled setting in a hospital, but I've given 120 milligrams of buprenorphine in 1 to 2 hours to settle people. I've never seen respiratory depression, to be honest with you. And I frequently give 40 milligrams, in one dose for women who are pregnant who come in severe withdrawals. I've never seen it. We've had combinations where I give someone 60 and 12 hours later, another 30, and they've never had. So I can attest to what you're saying. Clinically, I just haven't had a chance to write it up, but we've talked about this many times. And there's a study that I'm just working on now, and it's coming out that our average dose of buprenorphine in 100, I think we had 90 patients, was around 60 milligrams. And some people had 120 in that study, and there was 0 respiratory depression. So I haven't seen it yet.
Like sublingually in one day,
Sublingual, yeah.
like 120 milligrams.
Also, how do you administer that? No offense, like, that's a lot of fucking dope.
Yeah, but it's because you have to remember it goes back to, so I just because I've been doing this now, I've been doing livestock, so my liabilities, they even die is worse. But my argument all the time is if people are sick and in withdrawals, we have to treat it. And as Vincent, as you said, if you put somebody in bad enough precipitated withdrawals, you have to treat it. And the best treatment is more acute. And it works. The biggest issue is if someone's on methadone and you put them into PW, you get yourself into a lot of trouble. And I've gotten myself in trouble doing that before. But high doses of you have to remember it's a partial opiate agonist. And people are taking a full opiate agonist every day, fentanyl. My partial opiate agonist is not going to do what fentanyl is doing to my patients. So there's really not any liability. I say people use off-label use of fentanyl every single day. The fentanyl they're using on the street is off-label use. So using an off-label partial opiate agonist is not going to cause respiratory depression. That's my
Thank you. Excellent commentary. And then from the back.
Yeah, I mean, I in a couple of cases got up to 96 or 100 milligrams of buprenorphine,
And we've been on the phone together with these kids.
and these patients are fine. And also, in the era of fentanyl, even like our sublingual doses of buprenorphine, and I think we've had all sorts of weird and wonderful combinations where, there's a few patients I have who are on Sublocade plus they still feel better, and it's just on the additional 24 milligrams of buprenorphine, or some people I switch to 40 to 48 milligrams on a regular basis.
Great. So a wealth of experience in this room, which is amazing. And I know that, I guess if there's one more, you've had your hand for a while, one more very quick comment or question, and then we shall adjourn.
Might not be a quick answer. So we see a lot of patients that have been on Sublocade for a while, but now they want to rotate to methadone or Cadian. But because Sublocade lasts like forever in your body at that point, like how do we do that safely? When do we start methadone again?
Okay. I mean, that's actually a very quick answer. We just restart the methadone. There's no problem. Yeah. I mean, whether it was 2 weeks ago or 4 weeks ago, we can just add that back on if that's what they want for whatever reason. We don't see any particular complications with that. No, we just titrated exactly the same way. Yeah. All right. I know there's hands, which is amazing. It means people have things to say, and we can say them all in an individual format, one-on-one. But thank you all so much for coming today and for being interested in this topic. Keep on taking great care of patients.